Welcome to Healthbeat, Bigisisa's monthly television program that checks the pulse of our healthcare system. I'm Mia Malan. Drug dependence has become a public health and policing challenge. Our National Drug Master Plan, launched 5 years ago, recognizes addiction as a chronic disease affecting the brain and behavior. The plan follows evidence-based strategies instead of some of the traditional approaches that haven't been successful. It looks at ways to get people who use drugs onto treatment and into rehab centers early. But in the eyes of the law, people who take and push illicit substances are a problem and need to be punished. And so we go through a cycle of arrests and reoffending, a process that sucks up money and achieves little. A Healthbeat team travelled to Westbury, west of Joburg, where residents are trying to replace drugs and guns with skills and purpose.
By the time Bridget Munich walks to work in bright sunshine, the streets of Westbury are quiet.
People in the community, if it's daylight, then it's their time to sleep. So for us it's the day and for them it's night.
Auntie Bree, as people call her, grew up with illicit drugs.
What I personally experienced in my days with my brothers, they used the dagga and mandrakes, but those dagga and mandrakes, they were very calm.
She says drugs like tick or crystal meth are different.
Because the people don't sleep. They don't sleep, they're running around like mad people in the community.
Showing you that they have been met with rubber bullets as well.
Westbury was one of the first suburbs black families were allowed to move to in Johannesburg in the 1960s under apartheid legislation.
You know, there's families that live 12 in a bachelor flat. There's unemployment, there's poverty.
Drugs and gangs have turned this suburb into one of the city's deadliest.
If you're a teenager and you see that your mom is struggling, and here comes a drug dealer and put something in your hand, and that's easy money, then that started with being on the corner, selling drugs. Because now you don't even realize that your life is in danger.
Promises are made, and then in the end, nothing happens.
Generations trapped in a drug pattern that's hard to break. By the 90s, Westbury had the highest rate of mandrakes use in the country. Heavy-handed police crackdowns have done little to break the cycle. Provincial Police spokesperson Brigadier Brenda Muridili is optimistic about the latest plan.
The area is regarded as having been stabilized in a sense that we do not get as many incidents as we used to before the intervention, because that was the national intervention, and we brought in specialized units from the National Intervention Unit, and we had our tactical response unit. We also have working together with other stakeholders.
But Auntie Bree has mixed feelings about the police, saying they did little to stop local dealers when her sons struggled with drugs.
I didn't know they were on drugs. And then I saw the monsters, where they became very aggressive, very, very aggressive. I used to phone the police, 2 o'clock in the morning, no help. I couldn't go to my family because she can't come here because her son is going to steal. So it was very hard for me as a mum walking the streets of Westbury.
Bridget won't accept that the area's children will only ever be shaped by gangs and drugs.
We need to bring back the positive in our community and forget about the negativity. We need our Westbury place of dreams. We need it back. And I firmly believe that God is going to give our community back to us. That's why we want to change the mindsets.
She runs a centre to support the youth and keep them occupied with positive things.
I can proudly say that we replaced the guns and drugs with our skills development program. I think if you don't want to do the A class or the coding or the computers, we have the other skills, like the performance arts. We have the women empowerment, where we do permanent pets, sanitary pets. Then we take it to the schools.
The Westbury Youth Centre sees young people as future leaders and problem solvers.
I work with the strength of people. Even if somebody that's on drug walks into my space, I don't see the negativity, the drug, and there's a soul in this body, and there's a brain in this body. And these children got dreams, they've got visions, but so many of our youngsters are in cold graves. They cannot, the dreams are gone. And it's so sad in this community that we are losing so many lives.
Julian Rademeyer from the Global Initiative Against Transnational Organised Crime joins me in the studio. Our National Drug Master Plan says we should reduce the supply, demand and harm of illegal drugs. What does that mean?
Well, in short, it means that we reduce the supplies of drugs coming into South Africa. We reduce the numbers of people that use drugs, and we help to address the harms and the medical crisis that drugs are causing.
Are we getting it right?
I don't think so. We're seeing increases in consumption of drugs. We're seeing a steady flow of heroin into poorer communities, into small towns where previously heroin use was not prevalent. We're seeing methamphetamine production increasing. So the problem has been getting progressively worse.
Let's narrow all of those things down to Westbury that our team visited. Why is there still a drug cycle? How do those things play into this?
Well, the tragedy of Westbury and other parts of Western Johannesburg is the same as the tragedy we see playing out in gang areas in the Western Cape, in the Eastern Cape. There's a cycle of abuse, a cycle of violence that has been continuing for decades. There are high levels of corruption within police, which facilitate the activities of drug gangs. We've seen increasingly fragmentation in gangs, new gang structures evolving and emerging. The flow of drugs continues largely unhampered. In many ways, drug supplies in South Africa are centralized and controlled by many of the larger Western Cape gangs, and they provide a conduit of supply to gangs elsewhere.
In October, we've seen quite a few media reports of drug mules who were arrested at points of entry or borders. How effective is such a strategy?
I think any strategy where you're trying to police drug trafficking 1 kilogram at a time is doomed to fail. These are low-level people, some of the most vulnerable people in the supply chains. Many of them are women, many of them are coerced or threatened or are in such a position of vulnerability that they have no other choice. No one willingly gets on a plane and shoves 200 pellets of cocaine in their stomach. And if you look at what your average mule can carry, an experienced mule who's been on a few trips, probably up to just over 1 kilogram. A new recruit, for want of a better description, probably less than half that. It's quick and easy arrests. It doesn't get to the root cause of the problem. And the root cause of the problem is complex organized crime networks and the enormous health crisis that we face as a society. If you're someone who's looking for treatment due to addiction in South Africa, it's pretty difficult to find that treatment. Treatment in South Africa is a business. And the poorest of the poor, there's very few opportunities or places for people to go Simple things like methadone treatment are unavailable to the vast majority of people who need it.
Julian Rodemeyer from the Global Initiative Against Transnational Organised Crime, thanks for your time.
Thank you.
After the break, Mamelodi's heroin treatment program. You with Healthbeat, and we're focusing on drug dependence and proven ways to deal with it. A revised National Drug Master Plan was launched 5 years ago to nip drug use in the bud through early treatment and rehabilitation. Some aspects of it are working. Our team visited a project in Mamelodi funded by the city of Tshwane.
On the grounds of Mamelodi Hospital, there's a symbolic tussle going on. To stay clean or to allow drugs to triumph over wellness and treatment. This is a branch of COSUP, a community treatment program for people who use nyaupe and heroin.
Yes, and then my name is Jabu. Yeah, and I am beautiful. Yeah.
Nyaupe is a concoction of heroin and dagga and whatever else illegal drug makers add to it. It's injected or smoked and is said to have first popped up 20 years ago in townships like Mamelodi.
It's easy to be tempted because whenever you just go out that side of the yard, they are here. Or it is sold like sweets. I came in with that saying, I'm going to the right place. I know they're going to help me.
Nyaupe is what's brought Gaugelo Baloyi to COSUP.
Come in.
He became dependent on it. He's new to this program, which uses methadone to wean people off heroin. Methadone curbs heroin withdrawal symptoms and is only taken orally, so there's no sharing of needles. When needles are shared, users can transmit HIV and hepatitis C to one another. To the brain, methadone looks like heroin but doesn't cause as much of a high. So if you don't get another dose soon after the high wears off, your body doesn't crave it as much as with heroin. This is called opioid substitution therapy. It's safer for Gaugelo to get his methadone under watchful eyes here at COSUP than to take his chances with street heroin.
The medication, it is better than the substance I was taking in terms of finances and then in terms of the way I was given.
People on methadone are generally more productive than people who use heroin. Gaugelo says he's regained the trust of family and friends because he's no longer roaming around looking for drugs or hustling for money.
Although they are still having these doubts, whenever I can go like 5 hours not being visible in their eyes, and they will start like checking where it. Eventually it's working but anyway, they are the pillars of my health.
COSUP is run by the University of Pretoria and funded by the city of Tshwane.
So from those humble beginnings in 2016, it has grown because there's always a need. There's more and more substance use in the city. At this moment, we have about 850 to 950 clients treated here from at COSUP at the various sites.
Vuga Buthelezi manages medicines for the 16 COSUP centers in Tshwane.
COSUP issues around about 130 liters of methadone every month. So that needs to be controlled and managed.
Social and health workers visit areas where people who inject drugs hang out.
We provide something that is called a street medicine. We do HIV testing. We do as well, abscess care and wound care because we know that people who use drugs are sometimes using injections, and that is a big part of our programs.
They sometimes have to reuse a needle, which becomes very problematic for their skin. We limit the number of abscesses that they have to deal with by offering sterile needles for use every time they have to inject.
Kgaugelo comes to COSAP daily for his 6 milliliters of methadone. He seems determined to stay off Nyaupe and eventually wean himself off methadone.
Try to hurt yourself. You can be that person you were before. The legal back and beat that soundbite and start being positive with everything you do.
Andrew Scheiber is a medical doctor who works in harm reduction research and policy. He joins me online. Andrew, what is harm reduction?
So when relating to drugs, it's the policies, the practices, and issues that can help a person make healthier decisions. And it doesn't necessarily require the person to stop taking drugs. It helps the person to make decisions and to be accountable and really provide access to services.
So there's a lot of evidence that one form of harm reduction, methadone, to treat opiate addiction. There's so much evidence that it's on the World Health Organization's list of essential medicines for this purpose. Yet it's only available at very few government clinics in South Africa. Why is that?
So there's no doubt in our National Department of Health's perspective that it works and it needs to be done. The challenge at the moment is getting the medication listed on our essential medicines list for that indication. Currently, methadone is available in the public health sector. It should be at least in all hospitals, because when people are admitted to a hospital for any reason and they have opioid dependence and they go through withdrawal, the government recognizes that people should be treated with methadone to avoid the withdrawal so that they can have their other treatment. The challenge so far has been that our primary healthcare platform is not yet being tested to be able to provide that service where it's needed.
You've mentioned that one of the problems is that methadone is not on our essential medicines list. What needs to happen for it to be put on there?
The Essential Medicines List Committee have reviewed the evidence and have said very clearly that it works and it's needed. And they've given a recommendation to the National Department of Health to collect data on the feasibility of doing this in a primary care setting. This recommendation was made 3 years ago, and now the Department of Health has put out a tender to do 2 pilots. It's a very small number, but the idea is it'll show how this will link into our context, how the services can adapt to providing people daily treatment initially, how the training needs to adapt to our context, what materials and tools we would need to monitor patients and keep them safe.
Some people would say, why would you make it easier for people to do something illegal? How do we get around that?
Moral judgments or personal perspectives of drugs or anything can prevent people from accessing life-saving interventions. We've got very good data to show in the city of eThekwini, where the needle and syringe service was stopped for 2 years, how now, since we've done another follow-up study, the HIV burden is much higher and the hepatitis C burden is much higher. So it's this recognition that as public health individuals and society, while we might not agree with something, we want and have a responsibility to keep people alive and enable them to have access to services.
Something that often prevents us, other than morals, to roll out harm reduction programs is cost. How expensive is it, and is it more expensive to not treat or more expensive to treat?
There is very good global data to show that needle and syringe programs are cost-saving. They're one of the least expensive public health interventions. And we're not talking very, very large numbers. We're talking a notable number of people who inject drugs, potentially around 82,000, perhaps more in South Africa. But with every person who becomes HIV infected, we have large numbers of people who need lifelong treatment, increased likelihood of TB treatment, increased likelihood of transmission to other people, elevated risk of death.
Can addiction be cured?
It's very important to think of it as a chronic condition. So like hypertension, can we cure hypertension? Can we cure diabetes? Some people may shift their life that's no longer a problem. So it helps to think of it that way. Medical aids should be providing these interventions because they're cost effective.
Do medical aids provide them?
They don't. They do 21-day with inpatient withdrawal, which is very expensive. It doesn't work. It's actually not recommended because if people come out of one of those 20-day inpatients, they lose their tolerance. If they return to use, they've got an increased risk of overdose. If they inject and they use a contaminated equipment, they've got an increased risk of HIV and hepatitis C.
Andrew Schreiber, thanks for joining us. After the break, Portugal's decriminalisation experiment. You with Healthbeat, we're discussing illicit drug use and legislation. With me in the studio is Charity Monareng, who is a policy reform activist and the director of SSDP International. She's also a PhD candidate in public law at the University of Cape Town. Charity, welcome. Tell us, what does SSDP stand for and what work does it do?
Thank you so much, Mia. So SSDP stands for Students for Sensible Drug Policy International. We are the largest grassroots network of students and young people working to ensure that there's sensible drug policies that are entrenched in human rights and harm reduction.
Now, your interest in drug policy arose because you were really fascinated by gangs. Tell us more about that.
So I started doing my honours in at UCT on education in Lavender Hill at the time, and Lavender Hill is rife with gangsterism. I was always very interested in how young people got involved in gangs and also what they think would be needed to stop gangs. And as I delved deeper, I realized that gangs actually fulfill a certain purpose in communities. They create an economy in communities. Even though it's illicit, they're able to feed their families because of the economy that is surrounded in gangsterism. So it was like a natural progression for me to get into drug policy.
How are these policies playing out in South Africa?
I mean, 15 years of advocacy, and at least we're starting to see government officials even talking about harm reduction. Harm reduction is mentioned in our National Drug Master Plan. And so there are different organizations and institutions that support harm reduction because they understand what it is.
So why are we still so criminal focused? You know, if it doesn't really achieve anything other than filling up our jails.
We're already labeling people who use drugs as criminals because our laws allow that. Our Drugs and Drug Trafficking Act say using drugs is criminal, and yet we have a harm reduction plan. These contradicting laws make it difficult to move away from a criminal aspect and really use like a public health perspective to addressing drug use.
Let's talk about Portugal. What happens there?
And I think Portugal is a good lesson because initially it was like this golden standard. We still talk about Portugal at the international, national level. Lisbon, or one of the cities, was like the heroin capital in Europe. And when they introduced decrim, the heroin levels or prevalence of drug use in the country dropped because people were actually accessing services and not necessarily going to prison. So they shifted the thinking that drugs was a crime to drug use actually being an illness. So when you term something as an illness, it means there needs to be a public health response to it. It means that people and the health system was in place to ensure that we are catering for this vast number of drug users in the country and not necessarily overcrowding our prisons like what we're doing in South Africa. So that's what worked for them, but they didn't foresee like recessions, meaning that funding into harm reduction or decrim would deteriorate because the economy wasn't doing well and they had other priorities. So lots of lessons to learn from there.
We've got so many things that compete for money when it comes to policies in South Africa. So how would we afford this?
So it's cost effective, actually, because if you think about the cost of keeping a person in prison on the taxpayer. So in Portugal, for them, when they decriminalized, it cost a taxpayer, I think it was $10 a year. to make sure that DCRIM worked. It's a cost-effective method because we're now shifting and mobilizing resources to address the demand. Whereas now our resources have gone to dealing with the supply of drugs, but yet you're trying to stop drugs and yet there's still a demand. So we need to do things, simultaneously and make them work.
Charity Munering, thanks very much for sharing your time and insights.
Thank you so much.
That's our show. Let's strive for drug policies based on evidence and human rights instead of prejudice.